Hi, everyone. Good morning, good afternoon to you all. Thank you for joining and welcome to the webinar, A Different Kind of Gap, Maintaining and Accelerating Progress in the Fight to NTB. I'm Sochi Sanchez. I'm the director of the Secretariat of Action. Action is a global health advocacy partnership consisting of 14 locally rooted independent civil society organizations working across 5 continents, driven by a shared mission to ensure equitable health outcomes for all. And this year, we're excited to celebrate our 20-year anniversary. Before I hand it over to our moderator for the session, I'm going to give a brief overview of some logistics. So during our 90-minute session, we have live French interpretation. So if you need to access that, please make sure to switch over to the French channel. That should be at the bottom of your screen where you see interpretation. Please also feel free to introduce yourself in the chat and share where you'll be joining us from. In addition, we will have a brief Q&A at the end of the discussion. So again, we invite you to also put your questions into the chat as we go. So with that, I'm very excited to introduce our moderator today, Rosemary Mburu. Rosemary is the Executive Director of WACI Health, who is a member of the Action Partnership. Rosemary really is a true leader when it comes to civil society engagement around key advocacy issues, and we're really excited that she could be here with us today. So Rosemary, over to you.
So many thanks, Sochi. Good morning, good afternoon, good evening, dear colleagues. Depending on where you are joining us from, it's a great pleasure to help facilitate this webinar. We are excited to be able to convene as communities, as civil society, as partners, to have this discussion. This is our webinar titled A Different Kind of Gap, Maintaining and Accelerating Progress in the Fight to End TB. And we are going to be hearing more about the report, A Different Kind of Gap, a little bit later. The objectives of this conversation. So first of all, it's always good to come together as stakeholders in the TB response, to have a conversation, to take stock of what is happening as a community of advocates and partners who believe that, yes, we can end TB. For this conversation, we are going to look at 2 specific objectives. One is to increase awareness of the funding gaps for TB and the implications those gaps will have in TB-affected communities. So that's around funding gaps for TB. The second one is to encourage ourselves as advocates and also to encourage donors and TB champions to take action. So we are really looking forward to seeing what actions we can take, how we can strengthen our voice in the advocacy towards closing the funding gaps for TB. So just a bit of background in terms of why this is important and why now is the right time for us to have this conversation. I have 3 points to mention, regarding that. One is to recall, let us recall that COVID-19 hit TB response very hard. And I know the impact of COVID-19 on TB and actually, on HIV, on malaria, on social protection and so many other things is still something that we are recovering from. But I think it's important to recognize the momentum that we have built as a community of advocates, as donors, as TB champions, and the work of community leaders backed by combined TB and COVID-19 funding has made a remarkable comeback. We know that 2022 was arguably the best year in history in terms of the number of people receiving quality TB diagnosis and treatment. During the pandemic, people treated for TB decreased from 5.8 million in 2019 to 4.7 million in 2020, but then rebounded to 6.6 million in 2022. So there has been momentum there. That's remarkable momentum. while not forgetting that even with that momentum, we know that inequalities still exist. So we are not blind to that fact, but really flagging that there has been momentum. And so we cannot afford to risk losing or slowing down this progress. It's very important that we grab the momentum. It's very important that we don't lose the momentum. So the other point to raise as a framing and background for this conversation is that we know many of us maybe are in implementing countries, and we know that countries have started submitting their national 3-year plans for grant cycle 7 to the Global Fund. And it is clear that countries are developing some of the most ambitious plans in history, some of the most ambitious plans that we have seen. For example, many of those plans in TB priority countries such as Bangladesh, DRC, Congo, Nigeria, and Uganda include plans to expand innovations, for example, molecular diagnostics as the initial test. But financial gaps are actually glaring around that, and the cost of virtually all country plans is well above the money available to fund them. And so, there are serious risks to health of people and communities in this building the gaps if these gaps are not addressed. And so I think it's about the momentum, is about making sure that we grab the opportunity. And we are going to be hearing a lot about that later on. And we also just came from the UN high-level meeting on TB, and commitments were made. So this is really great in terms of the conversation we are having now. So to help us unpack a little more of that is a panel of great advocates, partners. So I'll just quickly introduce the panelists. We have Eliud Wandwalo. He is the head of TB programs at the Global Fund, and he will speak on the grant cycle 7, priorities above allocation request, and what the priorities above allocation request mostly covers. We also have Suvanand Sahu, who is a Deputy Executive Director at Stop TB Partnership, and will speak on the global TB response and why it's critical to maintain the progress of at least 2 years and expand funding for TB. We also have Caroline Mburu, who is a TB survivor, a TB champion, and will speak on the impact of TB programming and the direct implications of failing to fund the TB response. We have Cindy Bola, who is representing Carol Nawina, also works at Sitam Plus with Carol, and is an advocacy and grassroots officer, and will speak on the impact of TB programming and the direct implications of failing to fund the TB response, and specifically looking at community involvement. We have Kenneth Prudential, who is the head of advocacy at ASAPSU, an action partner as well, based in Cote d'Ivoire. As an advocate from an implementing country, will speak on the impact of the Global Fund and other TB responses in country, as well as what the priorities above allocation request looks like in Cote d'Ivoire and its possible implications. We are also joined by Honorable Joseph Munsanje from Zambia, the National Parliament of Zambia, who is also a vice chair of the Parliamentary Caucus for Disability, Inclusion and Rights. So that is our panel today. And to take us forward to the next segment and to unpack a bit for us, giving us an overview of a different kind of gap, I'm going to invite Maddie from the Action Secretariat to take us through an overview of this asset. Maddie, over to you.
Great. Thanks so much, Rosemary. Hi, everyone. Thanks again for joining us today. So as Rosemary mentioned, part of the reason why we're here today and why we've been sort of talking about this gap is that we started working on a TB advocacy asset last fall ahead of the UNHLM on TB, when the first window of applications to the Global Fund Grant Cycle 7 had started coming in, and we were hearing intel that the gap between the money needed and the money available for TB programming was already looking like it was going to be a huge difference. So we started digging into the data available in the Global Fund applications to figure out what that gap was looking like across the board, across all of the country applications that had come in. So keep in mind that there's 7 windows, And in just the first round of applications in window one, we were getting somewhere around $500 million in that gap. So this is called the Prioritized Above Allocation Request, or the PAAR. And this is part of the country proposals where countries are encouraged to include within their funding applications a PAAR with priority interventions that are part of their strategic plan, but they know cannot be funded because of the allocation they're getting in that country. But they keep these sections in the proposals so that way they are still included in the TRP review and then can be added to the register of the Global Fund's unfunded quality demand. More simply put, it creates a list of pre-approved interventions for countries that they can immediately integrate into their existing grants if any savings are found or additional funding becomes available. And what's different this time around, and we'll speak more on this later, but there's always going to be an expected PAAR in any grant cycle. But this time around, it's really, really large. And that is because, as Rosemary mentioned, we've seen a huge increase in ambition, especially over the last 2 years and coming out of the COVID-19 crisis. So that ambition paired with the high absorption rates we've been seeing, meaning that countries are able to spend the money they get faster, and the higher cost of the new treatments and tools means that, simply put, more money is needed. So like I said, we did our initial analysis. We saw around 500 million for that gap. We updated our analysis earlier this year after, you can go back 2 slides. Thank you. We updated our analysis earlier this year after windows 2 and 3 came in. And for around 63 countries, the total prioritized above allocation request just for TB was around 1.1 billion. We know that in early February during the Stop TB board meeting, the Global Fund shared that they were looking at around 1.2 billion. But either way, the exact number doesn't really matter. The point is that it's a huge gap and that this will have serious implications for the global TB response if it's not funded. And this number will continue to grow as the remaining windows of applications come through. So now we can jump over to the next slide. Thank you. So to break this down at a more simple country level, just to show that, again, big number, but it will have real implications at the country and local levels. So we just pulled a few examples of each country's prioritized above allocation request. So for Cote d'Ivoire, it's 10.3 million. For Kenya, we're looking at 24.8 million. Nigeria, 104.7 million. And India, almost 116 million. And again, that's just for TB, doesn't say anything of HIV, AIDS, and malaria. So if we break that down again, more simply, next slide, looking at just one country case example, just to show that what types of interventions are in the prioritized above allocation request. So we used Kenya, again, just as an example. And as you can see, nearly half of their total PAAR is for TB diagnostics, treatment, and care. That's the bread and butter of the TB response. So how can we continue to curb TB rates if countries don't even have the means available, for diagnostics? That's kind of, aside from prevention, that's stage 1 of the response. Next biggest chunk is specifically for drug-resistant TB diagnostics, treatment, and care. That's around 16%. And then the remaining pieces cover collaboration with other sectors, key and vulnerable populations, program management, prevention, and RSSH. So again, there are huge risks if these gaps aren't filled. We've seen historic progress over the last couple of years, and these plans, because they're already included in the country proposals, will already be vetted and budgeted. They just need the money to fund them, and they would help drive rapid life-saving results. It would undercut these countries' historic level of ambition. It would risk slowing down the adoption of new tools and treatments that we know are coming out, such as the recently approved and WHO recommended BPAL regimen. And it would set up the targets of the UNHLM for failure because we can't meet those targets if we don't have the money available to fund them. And so that's all for TB Asset. Back over to you, Rosemary.
So many thanks for that, Maddie, for giving us that overview. And for colleagues who maybe have not participated in the country level application process, every country at the beginning of the application process, every implementing country gets an allocation envelope that tells you this is the envelope to budget within. And so the prioritized above allocation requests are those areas that, different demands that countries have that actually are prioritized, but above the allocation requests that the countries actually include in their application. And to tell us a little more about that, I want to bring Eliud. And Eliud, I read your blog on World TB Day. You are talking about the fresh momentum. You are urging the community of advocates and funders not to lose the momentum. And I think it's really well connected to the conversation we have here today. So I'll invite you to tell us a little more about the current state of play, the Grant Cycle 7, what is in there, and connecting it to the assets that we are talking about today on a different kind of gap. Over to you, Eliud.
Thanks, Rosemary, for that. And also, I would like to thank Action for inviting the Global Fund in this important discussion. And it's true, this is a different kind of a gap. I've been working with the Global Fund for almost 10 years now, and I've not seen this kind of gap. As highlighted before, we usually have gaps, in terms of country request and what is available. But this kind of gap is different, and we can go into details why this gap is different. And in terms of the number, this number is keep changing. But what's more important is that the gap is big. And if you look at it, most of the countries, they really front load most of their funding in year 1 and probably year 2. But most of them would have a huge gap when it comes to year 3. So we are really talking of a real crisis, down the road in many countries. In terms of the funding, and I put just this slide to be able to show the level of funding between the Global Fund Cycle 5, Cycle 6, and the current Cycle 7. If you look at it, the number allocated to tuberculosis has been increasing. For example, in the Global Fund Cycle 7, we have 2.4 billion, which was allocated to countries for tuberculosis. So this is about 6% more compared to Grant Cycle 6. But even with this level of funding, we have seen countries are really struggling to prioritize intervention in this one. And when it comes to gap, as it was highlighted, it's about 1.1, 1.2 billion, depending on how you allocate most of the interventions to TB or cross-cutting. But most of this gap is really when it comes to diagnostics. That's where we struggle a lot, and mainly when it comes to cartridge. So that's where most countries are struggling. Now, I think we would go maybe at a later stage. Why do we see this level of gap? And I just want to highlight this is the gap for the funding request which were sent to the Global Fund. It doesn't really include the whole request of the country, because this will be a subset of the national strategic plan. So I guess countries probably have even bigger gap if you compare to what they have in their national strategic plan. So that's something which I wanted to highlight as well. I think one thing which I can just highlight here, what we are seeing in the previous years, whenever we get a TB application, we were not so worried about the gaps for tuberculosis for 2 reasons. One, TB was not absorbing all the money. So we knew down the line, this money will remain, and this was not a true gap because countries were not finishing their money. The absorption for TB in the last 6 years, 5 years, it was less than 70%. But the picture has changed. TB programs, they are now absorbing, very good their grants. In fact, the absorption rate of tuberculosis is the same as HIV or malaria more than 89% absorption rate. So we know what countries have submitted is a true gap. There will not be money remaining for this country to be able to reprogram. So this is what makes us worry a little bit for this gap. And I like the title. It's a different type of gap. Yeah. So that is one reason which we saw. But also, as I highlighted, we have seen very ambitious requests coming from countries. And it's not only ambitious that they will not be able to implement. We know countries have capacity to implement. We have been struggling before with many countries in terms of their implementing capacity. The countries were taking too long to scale up intervention. They would spend time piloting, discussing about policies. But this is not the case. There's a sense of urgency we are seeing coming from countries in terms of implementation. And we know, and we have seen this previously, we have a process here at the Global Fund we call portfolio optimization. Basically, this is additional funding which we give to countries based on what we see, our projection. If we think we have more money, we'll give more money to countries during the implementation period. This comes during the implementation cycle to be able to fill the gap. We knew many countries would be able to benefit from that. I think this good absorption, good scale up of intervention comes with a little bit of risk, because if countries will be able to spend all their money, that means we'll not have money for portfolio optimization, because before that money was used to fill the gaps, in terms of programming. Now, I just want to finish this part of my presentation by highlighting that apart from the funding which we have through the grant, TB also benefited from the C19 RM funding. This was the money which was available to respond to COVID. So in the C19 RM mechanism, we had 4 billion available for that, and some amount of money was allocated to mitigate the impact of TB, HIV, and malaria. And TB benefited. TB got around 417 million from that mechanism, which really helped TB program to buy a lot of commodity, such as digital X-rays and also diagnostic. So that is additional money which went to most programs, and partly that really helped to scale up a lot of countries' intervention post-COVID, because those were used by country for scale up. So we had a little bit of money there from that. I think just to complete this section in terms of the funding from the Global Fund, we also support countries also through other channels of funding. We have a blended financing, which we also do with a number of countries, where we work with a bank such as World Bank to be able to get a loan from World Bank, but Global Fund help to buy down the loan, basically taking the interest from those countries. So we have done that with India, we have done that with Indonesia, and also we've done that with Pakistan. And we are looking forward to do that kind of deals with other countries, which will help to be able to fill the gap. But having said that, the international funding is small. Global Fund being the largest funder for international
funding. Just to signal you to wrap up, we had time for you. Thank you.
Exactly. So I'm just finishing that. So international funding is just 14% of all funding for tuberculosis. So most of the funding is expected to come from domestic funding. So I think as long as we want to increase the international funding, we have to make sure that we also increase domestic funding for this country. Thanks.
Thank you so much. Thank you for sharing that and highlighting for us the momentum, even pointing to the fact that TB absorption of TB funding has improved. So continuing to point to the momentum, but also flagging that, look, we are not just talking about international funding. I think we also are aware that we really need to show domestic leadership by domestic financing. And now we know that failing to meet this gap will have serious implications for the health of individuals and communities. And the TB affected communities must really be at the center. And we know, even as we have this webinar, we are celebrating TB affected communities because this momentum is also a momentum that indicates the contribution of TB affected communities. So we want to turn to looking at what's at stake if we fail to meet this need. And we'll look at a country perspective. We'll start with Kenya, and I'll invite Caroline here. Caroline, can you provide insights from your own experience as a TB survivor, TB advocate, as a champion, on why efforts to scale up TB detection and treatment are so critical, and why new tools and treatment regimens would be so impactful? Caroline, over to you.
Thank you, Rosemary. Thank you so much. I will talk from the perspective of a TB survivor while explaining the challenges that most TB-affected persons are facing today. First of all, I will start with the issue of lack of awareness. Like, you will be surprised how many people do not know that it is TB they're suffering from when TB actually hits. There isn't a lot of information. Many people are not TB aware. For example, I'm going to use my case. When I was diagnosed with TB, it was actually a shock to me because I had no idea. I did not have, I was not exposed. I did not have a lot of information to know that this was TB. And this is happening to a lot of people out here. So that is one thing, lack of awareness. I will also talk a little bit about misdiagnosis. Currently, most TB affected persons, when they visit the hospitals, they have to visit at least 4 to 5 times before it is known that they're suffering from TB. Like in my case, I had to visit a health facility about 5 times. Each time I was given antibiotics before I was diagnosed. And actually the last time, around the 6th time I visited the hospital, I was actually admitted for 7 days. And this time I was diagnosed with severe pneumonia. So even after being admitted, I was not being treated for TB. So I had to go back home. And then after my condition deteriorated, that is when I had to go back again. And this was the time that I was diagnosed with TB. So this is happening to a lot of TB affected persons. You go to the hospital, they're not, first time around, you're not diagnosed with TB. So what happens? You go back home, you're increasing the risk of infecting those around you. The other thing is that your condition keeps deteriorating, because if you're not put on treatment right away, if you keep going back to the hospital, that means that you're affected, whatever organ has been affected keeps being affected. So misdiagnosis is closely related to late detection. So if I'm not diagnosed with TB as soon as possible, then there's late detection. And again, the same thing happens. If I am not diagnosed, I go back home, I keep treating myself with over-the-counter medicines. So this is another thing. So a lot of people, if you go to the hospital and then you keep getting sick, you keep treating yourself with antibiotics, what happens is your condition deteriorates, not mentioning that you risk your TB becoming resistant. And this is the case that is happening to a lot of TB-affected persons. So I'm also going to talk a little bit about the stigma and what it's doing, how it's affecting or impacting the fight against TB. So what stigma does is that it discourages those are affected from seeking treatment, from seeking care. And the stigma goes back to the lack of information. So if people don't know what this TB is, that TB is treatable, that TB is curable, and then they believe myths associated with TB, it brings stigma and it discourages these people from going to hospital. And then the same thing repeats itself. So if these people are not going to hospital, that means that they are getting sicker, they are infecting others, the risk of spread keeps going up. So it is the same thing, it is the same cycle. So really what is at stake here is lives. A lot of people are losing lives to this disease that is both treatable and curable. And if a person does not get to lose their life because of TB, there's this case of unnecessary pain and suffering. So why there's so much pain and suffering, and this mostly affects MDR TB patients. So these are the people that have drug-resistant TB. Their treatment is longer, their treatment is more expensive, and sometimes because of lack of enough funding, they have to go back to their pockets to cater for the medication to treat this disease. These people also need proper diet. They need proper nutrition. In most cases, when you go to remote areas, these are the people that are breadwinners to their families. So what happens if this person cannot go out there, look for food because they're down because of the disease they're suffering from? So this is happening a lot. That is why I would also say there needs to be more funding to make sure that there is a lot of awareness. Like in the case of COVID-19, there was so much information about it. You could literally hear children singing about the symptoms of TB. Like, we can do the same of COVID. We can do the same for TB to make sure that everyone is aware that if they cough, if they have these symptoms, go to the hospital, get screened, and then be put on medication immediately. And then that is one step that we can use to fight TB. So also more funding needs to be done to make sure that we have the right tools, we have the right equipment. So if I go to the hospital the first time round, let me be diagnosed with TB the first time round if I'm TB positive, so that we can reduce the risk of infection. So INC strides have been made when it comes to fighting TB, but more definitely needs to be made to ensure that we have enough funding to reach even people that are in remote areas, to make sure that no one is left behind, including the vulnerable populations. So thank you so much, but that is my perspective. Over to you, Rosemary.
Thank you so much, Caroline, and thank you for staying on time. Very much appreciated. And you've brought up so much from, you've pointed to missing people with TB, millions and millions of people who haven't been diagnosed and therefore haven't been put on treatment. You've spoken about stigma. We talk about community rights and gender perspectives, where things like stigma and other societal enablers when it comes to making sure that people can feel confident and comfortable to actually speak up and seek for diagnosis and treatment and so on and so forth. You've talked about universal health coverage as it links to TB, leaving no one behind, and the people who are most likely to be missed by health systems, etc. But I think above all, like you've said, what's at stake? People will die. It's as simple as that. If we don't fix this, it's as simple as that. We are not saving lives. People will die. And so thank you so much for being very, very straightforward with that. I'm going to take us to another country perspective. We are shifting gears here to go to Zambia. And I will bring Cindy to highlight for us, given the roles that Cindy, you play, and CITAM Plus, you as a champion, and CITAM Plus as a leading advocate and grassroots organization. What can you share about the critical role that communities are playing in driving this increased ambition for TB? We know you've also been working, like, for example, on the One Impact tool for community-led monitoring, and we know CITAM's role on this. Maybe share some reflections and perspectives from your end. Cindy, over to you.
Thank you very much, Rosemary. And as you've stated, our job is mainly in the community, and listening to the story like the one she just from sharing, it really makes us also get back to the ground to see why we have the passion for what we do, or why we have to advocate, because like what happened or what's happened to her shouldn't happen, as it said. So as communities, or as affected communities, it's very important for us to take ownership and to be part of the management of the disease. And that is why we have to make sure that we have CBVs on the ground, that when we have issues like the one she faced, you've got CBVs who can follow up. And also, when we work in communities, one of our jobs is to make sure that the efforts that the government is putting in place are really working. The services they've put in place, are the services accessible? Are they acceptable, or are they available? And we can only know this if we are collecting data on the ground. And one way of us which we're doing it, as you have mentioned, is the One Impact 2 in Zambia. With the One Impact 2, it's a tool which can be downloaded on the phone. Anyone who's a TB, let me just say anyone can download the tool, especially the affected communities or the CBVs. So they can download this tool, they can find data on TB awareness, they can find where we've got testing centers, they can report issues in case they went to a facility and they were not treated properly. They can enter all this data and it is sent to a dashboard where we'll be able to see some of this data, which we can also share with the facilities. So as you see, if this service can really work out, it can be easy for us to really have real-time data, which we can use for advocacy to fill in the gaps. Because most of the time when it comes to data, we only have the numbers, we don't have the qualitative data. Let me say maybe people are not visiting a facility. This data is going to help in the programming to see why are they not coming, because it will be collected and it will be reported on time. Currently on the One Impact 2 in Zambia, I'm happy to say that we've moved a step forward with the NTLP, the Ministry of Health. We are moving, we just left with a few things. It will be set up very soon and we are going to start collecting data and reporting on it so that it can be used to fill in some of the gaps. She also spoke of funding. As we are aware, most of the time, not most of the time, even now, TB is the least funded of the three diseases from the Global Fund. We would like to see more funding going to TB, as we know that it's one of the major killers, even for people, especially people living with TB. It would be good if more funding was given to TB. Well, our malaria colleagues have actually done more work compared to us. We hope that even as TB, we're going to follow that. We're going to follow that up and also ensure that we have funding. And one of the way we can do this is to ensure that as civil society we're included at the table from the initial stages. Because if we are planning together and we really bring out the issues, we really bring out the human aspect of it to see this is what TB is doing, this is the damage that it's doing. It's going to be easy even when the budgets are being done, when the planning is being done, to allocate more to TB, so that as she mentioned, we can look in the issues of, as she said, there's lack of awareness, there's misdiagnosis, there's stigma, there's treatment. And much of this is because when you look at funding, much of it normally goes to facilities or to the health facilities. There's normally very little, even as the funding is low for TB, it's even more waste for the communities. You find that the funding for the communities is much less. Much of it will go to diagnostics and medicines. But when it comes to raising awareness and stigma, addressing stigma, there isn't much funding. And we know, even if we have so much, we can have all the latest equipment, everything in the hospitals, but if people are not aware, they're not able to access these services. I feel still more we're not really addressing the issue at hand. So for us, we would ask for more funding towards TB so that we can, as communities, we can be very involved in ensuring that we complement the government's effort and bringing out the issues that are really on the ground for the government to better program in the TB response. I submit.
Thank you. Thank you so much, Cindy, once again, bringing us great perspectives from country level. You've touched on like really great points, reminding us about the role of community accountability, community-led accountability using community data, and you have indicated your work and how the tool is helping on that front. And when I say the tool, I mean One Impact tool that you have shared about. You've also spoken about the disease split, you know, from the allocation, from the Global Fund perspective. You've talked about the last mile, like how can we get people to actually come up for the services? How can we get people more aware so they can seek the services? How can we ensure that those people who have been missed by health systems are actually being reached at, or like when we do community-led monitoring, we are able to identify the gaps and raise the alarm. So I think I'll move us to the next country, and I like what I'm seeing, some commonalities in terms of messages from country level, but also with very distinct elements that are coming forward. And so I'll bring Kenneth Prudential from Cote d'Ivoire. So Kenneth, you are not only an advocate, but also you have been involved in, like, at the country level, the Global Fund proposals, development kind of process. And you've also done quite a bit of advocacy on domestic funding. So can you please provide insights on the current landscape of TB funding in Cote d'Ivoire at the national level? Over to you, Kenneth.
Hi, everyone. Thank you, Rosemary. And yes, our work in Cote d'Ivoire is very important as we lead studies. We work with the government. We also work with our partners, CSOs, on the ground to fight to eradicate TB in our country. When we were working on a study last year, we discussed with the community health worker. He said that it is the disease of the poor. Nobody cares. This is what many people that we work with think, because they think that they see the facts that we don't have enough funding for TB as a proof that it is not a disease attractive enough to be funded. We think as TB advocates that it cannot be the case. We cannot believe it because, as you were stating, as the different panelists were stating, there are many factors. However, in Cote d'Ivoire, the numbers talk for themselves. In Cote d'Ivoire, TB funding is always linked with HIV and malaria, as you know, and it is mainly funded by the Global Fund. The Global Fund fund 40% of the fight against TB. Other donors like PEPFAR, WHO, and others support the efforts of the government to eradicate this disease. From 2003 to date, the Global Fund has made available for Cote d'Ivoire an amount of approximately $1 billion USD to fight the 3 diseases. And TB has only benefited of 8% of this amount. This is a part of the Global Fund. At the national level, government is also concerned by the eradication of TB. As in 2021, they issued 30 billion of CFA domestic fundings to end the 3 diseases in Cote d'Ivoire. Once again, TB only received 7% of this amount. Since COVID, it has been very struggling to see exactly what amount is being affected to TB. Therefore, the gaps are really huge in Cote d'Ivoire. The National Program of TB estimates that to end TB in Cote d'Ivoire, we need 20 billion CFA. That means approximately 20 million USD per year. Currently, they only have the 3.5 billion CFA. It means 5.8 million USD. It means also that to end TB in Cote d'Ivoire, we miss each year 70% of the funding needed. This gap must be closed to be able to effectively fulfill the 2030 agenda. We had the chance to go to the UNHLM in 2023. It was a moment to strengthen the commitment from all the country members, but the gaps are persistent. We can see many unmet needs, but we can talk also about needs concerning research and development. We can talk about the issues around nutrition and TB. We can talk in Cote d'Ivoire about the contradictions between TB care and UHC implementation, multi-resistant TB, or the challenges faced by community health workers to reach out to remote TB patients. All these are important challenges. But one unmet need, I think my colleague Caroline Mburu has talked about it. One unmet need that we want to highlight here is the challenges concerning communication and sensitization around TB. There is a huge gap there on this point, why we know that communication is critical to fight this airborne disease, either to inform the general public on the bioregisters, to inform TB patients on the health centers in the areas, to improve the knowledge and access to diagnostic, to train better medical personnel, and avoid stigmatization and discriminations. These were key measures to fight COVID-19, which has many similarities with TB. This is why communication with TB is very important. Another item that I want to highlight very quickly is a quick insight on the challenges we face to increase co-financing commitments or in the country. This co-financing question were at the core of a panel we organized with many experts on TB fundings during the World TB Day. We focused our discussions on national budgets, and the National Assembly came, they were present, and they said that they want to reassure us that they will bring the support to NTB in the country, that they will continue to push for strong support from other MPs in the parliament on these questions. However, there is an important point that we need to know, and they said that it is that they cannot ask to the government for an increase of fundings for TB if this means that it should increase the overall budget. It means that every increase should stay in the budget presented by the government. So it means that for the challenge for us is to advocate, to have an improvement of the national budget for TB within the limitations of the overall budget for health. This should go through an important work on the inefficiency of the budget. In Côte d'Ivoire, we have 51% of inefficiency. We are now working to identify why this inefficiency is so important and the solutions to reduce it. The gains made can be used to contribute to the TB national co-funding targeted to key challenges such as communications on TB and the contradiction in TB care and WACI implementation. Another challenge, and I will stop there, is the transition of donors and the importance of our autonomy on health. Donors like Global Fund, PEPFAR, etc., will not stay forever, and we are targeting 2030 to end TB. It is critical that Côte d'Ivoire government and other African countries also improve their own capacity to take care of the fight against TB, because we know that transition has started with other partners like Gavi, etc., and will continue with the partners we have. We know the governments are working on it, on this issue, but the importance of this challenge of transition cannot be overstated to be able to really eradicate TB in our country. Thank you very much.
Thank you so much, Kenneth, for that. Once again, highlighting for us why it is very important that we have this conversation right now in terms of making sure that we don't lose the momentum, in terms of flagging the different kind of gap that we are having a conversation about. It's quite striking that the case of Côte d'Ivoire, just like many other implementing countries, we are talking about 70% gap in terms of the resources that is needed to end TB in Côte d'Ivoire. In many African, that is the same story in many African countries, in many national TB programs, the gap is alarming. And so, like, reflecting on how do we ensure that we as a global community come together, grab the momentum, and make sure that we can end TB. You have highlighted for us, communication and sensitization, and Caroline did the same, and Cindy did the same, along so many other things that you have reflected. Thank you so much for bringing the country perspectives, sort of like a deep dive on what's happening at the country level. Those are very valued for the conversation that we're having right now. I want us to zoom back out to the global view, and I'll bring Sahu here now to tell us a bit about what has happened over the last few years that made 2022 and 2023, like we said at the beginning, that these were the best years for TB diagnostics and treatment in history. How have countries, like India, Indonesia, Nigeria, the Philippines, been driving this progress? And what have they been doing that is different over the last 2 years? So I'll hand it over to you, Sahu.
Thank you, Rosemary. Good morning or good afternoon, good evening. Greetings from Stop TB Partnership. Thanks to Action Advocacy Network for inviting me. And I would like to congratulate everybody involved in developing this report. on the funding gap in TB. This is an excellent way of highlighting this. So I will try to speak about this issue in a way that I cover the good, the bad, the ugly. Maybe not ugly so much, but the good, the bad, and then come with some solutions. So the good news first. So as some of you talked about, the good news is about the unprecedented momentum that we have seen in the fight against TB. As Rosemary put it, these are the good years, and we have been all troubled by the setback that the global TB response received because of the COVID pandemic. But 2022 was a great year when 7.4 million people in the world could access TB diagnosis and treatment. This is a number that is higher than any other year. We still have a number of people missing, so a long way to go. But this is something that is unprecedented. 7.4 million got access to TB diagnosis and treatment in 2022. Further, for 2023, from the provisional data that we have, we are estimating that this number will, for the first time, exceed 8 million people globally. And this will meet the 2023 target for the UN high-level meeting. So that should be we should celebrate for that as well. So congratulations to all national TB responses, partners, and the advocacy community for all this achievement that has happened. We know we have to go a long way. We also hope that 2024 will be even better than 2023 because the UNHLM treatment target for 2024 is even higher than 2023. So that's the first point I wanted to make about the good news, great momentum in countries. The second I wanted to make about the good news is today we have some exciting new tools that is making possible what we thought in the past as impossible. For example, we today have ultra-portable X-rays that are enabled by artificial intelligence to give the report itself. We today have new rapid molecular tests, not just one, but at least 2 approved and many in the pipeline. Shortened and simplified treatment regimens. Imagine drug-resistant TB treatment was 18 months, cut down to 6 months now. And we also have some new digital tools that makes things possible to happen at scale. So these new tools are adding another possibility, another dimension of solving some of the problems that we had in terms of scale in the past. So the new tools are there. The third good news is, as some of you mentioned, in September 2023, the heads of governments and countries committed to a very ambitious, bold political declaration. 45 million people to be treated in the next 5 years. 45 million people to be provided preventive treatment in addition to that in the next 5 years. Also funding targets, 22 billion per annum US dollar for TB care and prevention, and another 5 billion per year for research and development. So great news. So these are the good news I wanted to highlight. Now comes the bad news. And the bad news is that the fight against TB is running out of money. Imagine you are in need of money, you go to a ATM and the ATM reads out of cash. How is the feeling? That is the current situation currently. So it is very simple to understand that increasing numbers of people diagnosed and treated need more money. We know that some national TB responses are now running out of money because they have scaled up their program. We know that some large, high-burden countries which have made rapid progress have adequate money only for the first 2 years of the global funding cycle. Remember, the global funding cycle is 3 years. I think Eliud also tried to say that. So some countries actually have money only for the first 2 years. In the third year, there is a lack of money for even essential commodities. That's not a good situation to be. The second point I wanted to highlight is, and great that this report is highlighting the UQD, the quality demand above allocation of global fund. That is 1.2 billion. But we must remember, as Eliud and some others pointed out, also Kenneth, I think, highlighted very well, that this is a subset of the total gap in the country. If you look at the national strategic plans, and as people said on this webinar, that national plans are becoming more ambitious, we are seeing a big gap there, much bigger, several times bigger than the UQD gap that we see in this report. So just wanted to highlight that this is a gap that is a subset of a bigger gap, but we have to make every effort to fill at least this UQD gap of 1.2 billion. We, from Stop TB Partnership, we also do this global plan to end TB. The latest one is 23 to 30. If you look through that, the full cost is estimated to end TB globally. And that is the basis also of the UNHLM political declaration, which is asking for $22 billion per annum. And what do we have currently? If you look at the WHO report, just about $6 billion per annum. So funding has to go up 3 to 4 times, not just in marginal increases. Same with the research and development. As I said, it's 5 billion committed per year in the UNHLM commitment. And today we have about 1.1 billion. So it has to go up again for more than 4 times. So now let me talk a little bit about what should we do with this kind of a good news as well as a bad news. We have to get the money there. And let me talk about first countries. Some countries are leading in making progress, and we must ensure that the best practices, both in scaling up as well as getting the funds, should go viral to other high TB burden countries. This is something that we have to do as a global community, and I think Stop TB, we are trying to do this as well. If you look at now, to be exhaustive and name all countries and go through, it's very difficult. So I will identify a few and quickly go through a few things. India and Indonesia, the number 1 and number 2 in terms of TB burden globally. They demonstrated great political leadership at the level of the head of state, not just the health minister, head of state. And this resulted in their domestic funding going up 2 to 3 times in the last few years. We have seen how this kind of political commitment can change the budget lines. They also implemented some very innovative things, which we'll not have time to discuss here, but great innovations are happening in both countries. We see in Africa, Nigeria, after years of slow progress, in the last few years, almost tripled their access to TB diagnosis and treatment. And this is one of the top high burden countries which never got affected by COVID in terms of the access to TB treatment. It went on increasing, right? Great progress, again, because of high level commitment and determined efforts by the National TB Program and the partners all coming together. We also have seen recently in Philippines, I was myself there, great political commitment right from the president level and the health minister, both prioritizing TB, making it not just a TB program initiative, but a whole of a society issue and a whole of a government response. We saw also in Philippines how the level of unprecedented level of awareness generation and things that are happening. I also participated in an event where they mobilized the society to break a Guinness World Record. So unprecedented access also, more numbers have been put on treatment in Philippines than ever before. And this is progressing very high. I will not have time to go through all of them. But what I wanted to make a point is that some countries are making great progress and we must learn and disseminate further. And just quickly to end, as somebody said here, the Global Fund commits only 18% to a disease, TB, which kills more people than HIV and malaria put together. This is unfair. And the Global Fund board, which will meet in Geneva this month, from Stop TB Partnership, we will put out a paper and we will circulate to everybody. You can have that paper. We are asking for a more fair approach in this disease, what is called as disease split, between the split of resources between the three diseases. And Global Fund had commissioned a report by Ernst & Young, and even that report is proposing the same. We must do a lot to increase domestic funding. We have seen in some countries domestic funding has increased. We have to work further on it. We have to mobilize the financial institutions in this world who have the money, the World Bank, the Asian Development Bank, the Africa Development Bank. We have seen some great initiatives in some countries where large amount of funding has been provided by these financial institutions, and there is scope for many more countries to be included in this. And finally, we also need to work on some innovative mechanisms of increasing financing. So I will end here, but let me just say that this different kind of gap is important. If it is not filled, it could lead to needless sufferings and deaths due to TB. So we must take it seriously. Thank you.
Thank you so much, Sahu, for that. You went into highlighting, basically pointing into the global perspective and giving us examples from a number of countries, including India and Indonesia, Nigeria, Philippines, again, speaking about the disease split and really highlighting the importance of us thinking about how we address this different kind of gap, because it can lead to unnecessary suffering. I think connecting very much to what the advocates from the country level had mentioned about what's at stake, and it's actually lives will be lost. And actually, you've also sort of set us ahead in terms of the open discussion, because after we hear the remarks from the MP, I was gonna turn to you and see what creative opportunities you see, to expand funding for TB, and you've highlighted for us a couple of those opportunities. But let me turn to Honorable Joseph Munsanje from Zambia. I hope he's able to come forward. I see you are here, Honorable. And I just want to turn to you right now, having had that conversation, and to say, first of all, that we are honored to have you join us, and we appreciate your time and the work you do at the National Parliament as an ally, as a champion for TB. Kindly, could you share insights you have as to why this should be a priority for everyone, everywhere, including for decision makers from countries where TB is not an immediate health threat? So over to you, Honorable Joseph.
Yeah, hello, Caroline. Oh, is this Evelyn? Sorry.
It's Rosemary.
Oh, Rosemary. Yeah.
Yes.
All right, thank you so much. I'm just walking to a place where I can, oops, we're just dealing with road shedding and rain here. So in a moment, I'll be, yeah. So thank you so much.
You are settled?
So yes, I'm settled now. We can talk. Yeah.
Okay.
That's right. So yeah, thank you so much for inviting us as the parliamentary caucus on the tuberculosis or ending tuberculosis at the Zambian Parliament, and I also chair, of course, the Disability and Inclusion and Rights Caucus. The other one, the TB, we've got our chair, Dr. Karira, who I think could not make for this meeting. The need to end tuberculosis by 2030 in Zambia is a very important subject in that as a country, we are definitely, we have had the TB scourge for many years, and we now are running the Ministry of Health. We've been a recipient of the Global Fund on TB, HIV, and malaria for many years, and we are trying to increase our domestic budget. And for the first time, our domestic budget has increased to 11.8% of our main budget in the country, which then also will see much more services being delivered to the TB detection, treatment, and care services. We are now also working with the Ministry of Health, just having commemorated our TB Day a few days ago in March, to ensure that we increase TB education and awareness to the communities in our constituencies and all over the country. Also for people to understand the signs and symptoms and be able to, use the health system when they are affected, to improve the diagnostic services in terms of both the health workers' capabilities as well as the equipment and related for them to do a quality job. And of course, also ensuring that a lot of young people become aware of these things. For example, issues of school-going children being aware, and because we believe that the young generation being aware will help us to deal with the TB scourge. And there is also the issues of TB and gender, which is also something we are tackling as a country. So as a caucus, we are working on relaunching our TB caucus, because we have recruited new members who may not have been in the parliament before, and also who may not have been involved in tuberculosis control in their constituencies. So with the new move, we are hoping that we can get as many parliamentarians as possible to be fully aware about these TB control initiatives that are being done in line with the National Health Strategy to ensure that services are available in every community, especially community sensitization, detection at the community level, referral from the community system, and treatment, especially treatment adherence, to ensure that we do not get the MDR tuberculosis, and also ensuring that there is accountability at every health center and every health system by both the health workers and also the utilization of the funds and related. So accountability is another area which we are also pushing to ensure that there is accountability in the delivery of services. So we can, I don't know if there are other areas which you would want me to cover, or if there are questions which people may want to bring about, which we can cover in this brief presentation on the areas that were given to me.
Thank you so much, Honorable Munsanje, for your reflections and remarks. We appreciate that, and they quite align with what we have had before in this conversation by the speakers who came before you. It's quite alarming, the kind of financing gaps we have for TB at country level and at the global level. And we are looking at how can we ensure that these gaps are filled so that we don't lose the momentum. And your remarks are very spot on in terms of accountability, in terms of making sure that we are working from a cross-sectoral point of view, whether it's TB and gender, TB and nutrition, and so on, as you have mentioned. And also the role of Parliament in ensuring that there is increased and efficient allocation for TB at the country level. And we appreciate the work that you are doing there through the TB caucus in supporting TB affected communities in our TB advocacy in Zambia. I want to just help us move faster because we are also drawing very close to time. I want to acknowledge all the comments that have come on chat. We see you. Robin, we see your comment about out of cash kind of campaign. It's quite striking that the national TB programs run out of cash, like during the second year or third year. And so very alarming kind of data and statistics. I want to check with Madi if we have any other questions, even as I turn to the panelists. I'm just going to come back to you for maybe one question as we wrap up, and also turn to the audience to see if you have a question. Kindly feel free to use either the Q&A there to put in your question or your comment. And for the panelists, I'll turn to you, Eliud, first, because throughout this conversation today, what we are hearing is that there's an increased ambition by countries based on the proposals that have been coming into the Grand Cycle 7. It's very clear that countries are ready to end TB for good. And so what do you think is actually fueling this increased ambition? So that's for Eliud. And then after Eliud, I'll turn to any of the advocates. It can be Carol or Cindy or Kenneth, either of you who has a reflection on, in terms of diagnostics. We know that there's a really big funding gap here. The Global Fund has estimated that about 60% of the prioritized above allocation requests is for diagnostics. Maybe you can reflect for us or speak on the impact of these new diagnostics that you have seen in your communities. And Sahu, in his remarks, made a point to what these new diagnostics or innovations are. And then I would say that we take that and then we see if we have more questions from the floor. So let's go to you, Eliud.
So, Rosemary, thank you. And I will not go through, all the reasons, because I think we have discussed during this panel, good absorption, good ambition. But I just want to highlight from the Global Fund point of view, we have seen huge decentralization and diversification of TB treatment approach. Many countries, and I think the agency was also created by COVID. We have seen countries moving from only public, facility-based treatment and TB approach to community, private sector. For example, in Nigeria, almost 45% of TB notification come from the community. So that kind of diversification, I think, is in many countries. And then I think the other issue, TB is no longer disease of poverty. And when I say poverty, yes, it affects poor people, but it's not cheap disease, as it was said before. Now, tuberculosis is a disease of options. We have many options, and it becomes a little bit expensive to be able to mount a quality TB treatment. And I think we see that countries, as one highlighted, they're going to digital strain, artificial intelligence is common, digital approach. So we are seeing that TB approach expanding. So I'll stop there.
Thank you so much for highlighting that. And indeed, a lot of this has been highlighted in the conversation. And I think we can also look at how can we as advocates help to to close this gap from an advocacy point of view, what needs to be done. And I'll also be turning to you, Honorable Munsanje, to see whether you have insights on the best way to appeal to policymakers in donor countries. But before I come to you about that, because you are doing a lot in national parliament in terms of TB financing from a domestic point of view, we also need to talk to policymakers in donor countries in terms of increased financing, whether it's through the Global Fund resource mobilization, that like the replenishment that is coming up, or whether it's through like the World Bank, etc. So your reflections on that. But let me turn to the advocates, Cindy, Kenneth, or Carol, either of you. Any final quick reflections?
Yes, yes. Can you hear me? Is it okay? Okay, yes.
Yes.
The item I want to raise here concern this the question of innovation in terms of diagnostics. For example, We know in Cote d'Ivoire that gen expert in one of the diagnostic that need to be present in all the anti-TB centers in the country is not the case. So the presence of this gen expert material in itself are what we can call an innovation for us. It's important that all the measures being taken ensure that we have these gen experts in the different anti-TB centers. The second point is that we need to also have a more precise look at the diagnostics on young children. This is an issue that is being raised in Cote d'Ivoire, the fact that gen expert or these types of diagnostic don't always capture the TB in the young children and the 5. We need also to think of new innovative methods to be able to diagnose children and be able to treat them as soon as possible. I will stop there. Thank you very much.
Many thanks, Kenneth. And I remember on World TB Day, the executive director of Stop TB Partnership, Luchika, was at the African Union Commission headquarters in Addis Ababa. And in her speech, she really highlighted the new diagnostics and talked about the portable x-rays that Sahu, you were talking about, how artificial intelligence is really coming to change the game. And I think that's something to leverage on in terms of the direction that new innovations is taking. It can really be a game changer, especially for low and middle income countries. I'll turn to Honorable Munsanje, and then after that, Sahu, if you have any final thoughts, reflections, we'll turn to you. And we will check if we have additional questions on the chat. Back to you, Honorable Member.
Yeah, thank you so much again. Basically, for insights into appeal to policymakers, what we see is that we need one of the things we're doing in Zambia is to interrogate the sector planning budget for Ministry of Health and the community development. So when we do the sector budget analysis, we then interrogate the budget with the stakeholders. And before that, what we have done is to organize an investment case discussion. So we have an investment case discussion with the ministry as a caucus to ensure that we point out the areas of funding where we would like to see an increase in funding. And this year, we have been informed by Parliament that as a health committee, we will be allowed to actually change the budget within the total headings. That allows us then to now say, okay, can we increase here and reduce here? You know, the way we see it as a committee. So we're using a two-pronged strategy, which we think can work for almost every country by building an investment case for tuberculosis in your country. And from that investment case, then you can engage with the ministers of finance on as they prepare the national budget so that we've got streamlined and integrated services that are able to cater for the various needs of the TB area of work. So that is, I think, my intake in the my take on how we can get to the policymakers to make the correct decisions. And of course, civil society needs to continue capacity building as parliamentarians and other policymakers, because not everybody in the committees, for example, is a former TB programmer like me. So we need a continued capacity building so much that people are brought to speed and aware about the latest initiatives and like we've talked about portable X-rays, artificial intelligence, and many other new initiatives, which for example, here also TB is associated with HIV in Zambia, where we've got almost 62% of the people dying of TB also being co-infected with HIV. So we're talking about new initiatives such as the vaccine for PrEP and all those kind of things, that can also intervene to help on controlling tuberculosis incidence and mortality. Yeah.
So many thanks for that, highlighting ways through which we could actually work around increasing national budgets And I think also in the conversation, Sahu and Cindy, you had also talked about the opportunity with the disease split, getting more money from the Global Fund. And I also want to point to the honorable member that in addition to that, there is also an opportunity for members of parliament in low and middle income countries like yourself to amplify also the need that we have to ensure that the Global Fund itself is fully resourced, so that even as we talk about increasing the disease split, we have an opportunity to target the international donor community and the upcoming eighth replenishment. We'll hear more about it in future conversations. It is an opportunity for members of parliament in implementing countries like yourself and your colleagues to actually champion that. Let me turn to Sahu for your final reflections.
Thank you, Rosemary. TB can be prevented, diagnosed, treated, and also treated to cure. With that in mind, I think it doesn't make sense if you don't make the money available to end the disease for good. I think we have to really think about it. I am a firm believer that there is money in the world. It may not be in the right places. If you have to save lives, TB is the place to put the money on. Remember that untreated TB has a 50% mortality. Half of them will die. Even if you treat TB, you see some of them are treated, not treated. 10 million people, 1.3 million is the mortality, much higher, 13%, much higher than what we saw in COVID. So if money is not made available, unfortunately, lives will be lost. The world has money, countries have money. We have to place the money in the right places to save people's life. So that's my plea. The second point I wanted to respond, there was a chat question on climate. Yes, TB is linked to climate through climate-induced migration and also the food insecurity that climate causes. Both are drivers of TB. Wherever there is migration, we see a flaring up of TB. Wherever there is food insecurity, we see a flaring up of TB. 20% of TB globally can be attributable to undernutrition. So that's a huge driver of TB as well. Thank you.
Thank you so much. Eliud, I see you have responded to the Grand Cycle 8 question, but I just want to make sure that we don't close any other reflection or final remarks that you might have.
I think we need to make sure that TB gets enough its own share of funding from Global Fund. That is very clear. And our independent report, which we commissioned, said that. So I think that's one. But I think more important, we need to make sure that Global Fund is full funded. It's good to divide the pie, but we need the pie itself. Because as we said, 76% of the funding comes from Global Fund. So it's important for countries to get that, apart from increasing domestic funding.
Absolutely. And thanks to Sahu for commenting about the climate change and TB. And I know that the Global Fund has developed messages around climate and TB, which I think are also very useful based on the question that has come. I want to check. I think those are all the questions we have from the audience, and we'll be transitioning to the closing remarks unless any of the community champions, advocates. We heard from Kenneth. Caroline, I see you have come. You told us that what's at stake is lives. Do you have any final thought, reflection before we close?
Yes, I'd close by saying that if we do not fill the funding gaps, what I said will happen. There's going to be increased rate of spread. More and more people are going to be infected with TB, and then the situation is going to get out of control. So I would say it's better we control it right now when we can, instead of trying to control it when it gets out of hand and almost everyone has TB. Thank you.
All right, Cindy, let me come to you. We are in closing reflections, even as we go to any other additional calls to action. Cindy?
So as a call to action, I would also speak of more funding towards TB. For Zambia, what I can say is currently the political climate and political will is there. It's very good. And we also have a cooperating NTLP who has been engaging us even during the writing process. I should say they engaged the civil society from the start, and they were able to sponsor us and to make sure that we participated until the end. So I feel when we talk to the funders, they should also be funding something that is working well, not only looking at what is not working well, so that we build on what is already working well so that we can fill in some of the gaps. Thank you.
Thank you so much. So as we come close to the end, we have taken stock of the current status of TB financing, specifically guided by a different kind of gap, the asset that the Action Partnership has developed to flag the urgency and the depth of the gap in terms of TB financing. And the conversation here has only looked at the financing that is coming from the Global Fund in terms of Grant Cycle 7. We have also talked about the role of implementing countries, partner countries, in terms of domestic resources. We have looked at gaps in domestic resource points of view. And we've also heard from all our speakers why it is important to not lose the grip on the momentum that we have made. We've also heard why it is important now to make sure that we leverage that momentum. We've heard why it's important to actually ensure that we make progress on diagnostics and TB, and that the ambition we have now is an indication that countries are ready to end TB, and we need to ensure that we get the financing to do that. We have also listened to the opportunities that exist. You know, the Global Fund Board is coming up. We have been urged to be champions for the disease split in terms of how we can ensure that TB gets a fairer share. We have also been alerted to the opportunity that comes with the Global Fund's eighth replenishment as a way to ensure that, first of all, we can continue to write proposals as countries. And so this is it. We have to make sure that it is very well funded. We have also seen the opportunity we have with members of parliament as champions at country level, at national budgets, and also the cross-sectoral elements that have come up, like TB and climate, it has come up, TB and gender, TB and nutrition, and so on and so forth. And also the community rights and gender aspects, stigma and discrimination, TB affected communities, key population, etc. And so I want to thank you very much and to bring your attention to the slide here to call us to continue to the conversation online as we continue to call for increased political will and resources to end TB. Those are our social media addresses at Action. And in the chat, the report has been shared. Many links have been shared. Kindly let's continue the conversation. And now we will have a group photo to close it all. And I thank you very much for your participation. It has been very engaging.